This is the sound of the phone ringing and ringing at a Lower Hutt clinic.
Welcome to High Street Health Hub. Please be aware our phones are busy. However,
That clinic has been in the news lately.
The future of High Street Health Hub remains uncertain, with authorities not ruling out cancelling its funding unless it can improve patient care.
That might be an extreme case, but High Street Health Hub is part of a much larger picture of GP clinics under stress in this country. Here's another clinic's voice message.
Due to high demand, there might be a slight delay for non-urgent appointments.
A slight delay, however, starts to look good when the prospect of practices disappearing entirely is a very real one.
So we've got real concerns that some practices may not be viable going forward, and we've seen examples of that start to pop up around the country.
And if your GP is still open and you've managed to get an appointment, it's going to cost you more, with doctors saying they'll be forced to raise fees because they're underfunded.
Well, primary health providers are rejecting Te Whatu Order's increase of 4% to core general practice funding. They say the government is shortchanging GPs whose margins were already pretty thin as their patients' ability to pay for more doctors' visits is frayed as well.
A GP shortage, a funding model that's being called not fit for purpose, a publicly listed company buying up clinics across New Zealand, patients waiting weeks, if not months, for appointments. And more than that, this palaver is costing taxpayers.
So for every dollar you spend in primary care, you save $13 to the New Zealand health system. The return on investment doesn't get any better in health, that you have to support primary care, you have to support general practice, you have to support what goes on in the community. Because if you think about it, if you didn't have access to general practice in the community, the only place you can get access becomes after hours, emergency departments and hospitals with late presentations. And what we know with that is people have worse outcomes when that occurs.
Kia ora, I'm Alexia Russell, and today on The Detail, Gwen McClure looks at the state of primary care in New Zealand. Later in the podcast, we'll come back to that clinic in Lower Hutt. But first, Dr Brian Betty is a specialist GP in Porirua and the chair of General Practice New Zealand.
Okay, let's start with the basics. How short are we on GPs in New Zealand? How many more do we need?
Look, at the moment, it's estimated we're probably short about 300 to 400 GPs across New Zealand. We should be training 300 specialist GPs a year. We've been doing around 200. This year's slightly higher, 230. So we're way below what we should be training, and we do have a shortage.
Okay, and when we say we have a shortage or we need more, what do we actually mean by that? What's going wrong in our healthcare system that would be fixed if we had more GPs?
Look, the basic issue we're seeing across the country is capacity issues. So there are many practices. We estimate up to 50% of practices have either got closed books, that is, they're not accepting new patients because they don't have capacity, they don't have enough general practitioners, they don't have enough nursing staff to meet patient demand. So capacity is probably the biggest issue we see, and the consequence of that and the problem with that is that puts huge pressure on things like hospital emergency departments, after hours services and hospitals themselves, with patients not being able to access care in the community, or leaving things till they get to a point where they have to present to an emergency department. So it's a real issue for the New Zealand health system.
General Practice NZ recently commissioned a study about unmet need in this country.
The report says GPs are put at significant risk managing patients with unmet needs. There's no additional payment for extra work, and some GPs knowingly don't refer due to the likelihood of getting declined.
But the consequence of that is those patients who should be seen as specialist, should be having an operation, are being sent back to the general practice and the general practitioner to look after. And that's a major burden on the practices. It's a major concern for patients themselves, and it's a major workload for general practitioners overall. So it was quite a revealing study that was looked at.
One of the things that I hear a lot is that we're losing doctors and nurses overseas, especially to Australia probably, because the pay is better.
There's three things that are happening. The College of GPs did a survey a couple of years ago, 2-3 years ago, and it discovered that about 50% of general practitioners were reporting severe burnout. That is, workloads, complexity of patients, patient demands, workloads had increased significantly. What we are seeing is GPs retiring earlier than they otherwise would. We see some GPs cutting back on the number of days they're doing because they want to relieve the pressure. And the other thing we are seeing is GPs moving overseas, especially to Australia.
Okay, let's talk about the funding model for GP clinics and how that works in New Zealand.
So, we run a mixed model. Basically, there's capitation. So if you sign up to be a patient in a general practice clinic, the government gives a set fee for the year. That is topped up by what you pay when you go in to see the doctor. And the average cost in New Zealand is $55, except for what are called low-cost access practices, where it's capped at $20 and they get a slight extra funding boost. So the capitation model itself, the problem with it is capitation's okay, but the model is not fit for purpose. So it was designed 20 years ago. Mm-hmm. It was based on age, and it was based on average attendance at a general practice, which was estimated to be about 2.5 to 3 times a year. What we've seen over that 20 years, we've seen increased complexity with patients, more comorbidity, patients living longer. We've certainly seen deprivation and equity issues, especially with Māori and Pacific, so a lot more complexity that general practice is meant to deal with. That is now not reflected in the funding model. So what we are saying to the government very clearly is this has to be revamped. And what the model needs to take into account is ethnicity, comorbidity, complexity, age, deprivation. So those factors need to come into play. And if that was done, it would rebalance the funding system so that the funding followed the patient.
It becomes cyclical, doesn't it? Because if you've got GPs who are burned out and retiring early or leaving the medical field, then you've got fewer GPs, and then the ones who are there are getting burned out, they're leaving, and so on.
Look, everything's connected. So the more you have this happening, the more the workloads build. The less capacity that hospitals have because of waiting times or issues, the more that puts pressure back onto the sector. So, you're right. Everything is connected. And, look at what we have noticed over the last 5 to 7 years is a marked increase in workloads. Complexity of patients, if what I've just said about hospitals not holding on to patients as long as they previously did, and discharging them earlier to the community, then what we are seeing is patients who are more complex, patients who are living longer, have got more complex medical needs, and that's falling back onto the shoulders of primary care, general practice and general practitioners and nurses. So, it is all connected.
All these problems in the sector have a very real knock-on effect for patients, as well as for the clinic staff. High Street Health Hub in Lower Hutt has been at the centre of a lot of this.
Well, a GP clinic in Lower Hutt, which was forced to stop face-to-face consultations for most of its 9,000 patients, this is because of staff shortages, it's hired a second doctor.
It started a year ago, one patient says, when doctors began leaving the clinic.
The last time I physically saw a doctor, I asked why they were all leaving, and this really stuck with me. She said healthcare shouldn't be a business, and this clinic is treating it as a business. It's not about the patients, it's about the money.
Kate Green is an RNZ reporter who's been following the story.
There was a mass exodus of staff late last year. From what we've heard, what we understand is that the doctors at first, there were, I think, fully staffed about 8 doctors. About half of them left for supposedly unrelated reasons. They moved to join a spouse in a different city, or they just took a job elsewhere, maybe better pay. So it wasn't directly related to the work pressure at High Street Health Hub, but it compounded an issue where the staff that were left were so overworked. We heard and have heard from multiple sources that all of the nurses resigned in one day. They just said, we don't feel comfortable working under no GP supervision. You know, we don't have the ability to prescribe or to make decisions about people's health without that doctor oversight. And so they said, we just can't do this anymore.
So how many patients are enrolled now and how many doctors are serving those patients?
So they've got a roll of 9,000 patients. And until very recently, July 15th, they just hired a second doctor. So until then, they were being seen by one doctor. And they were based off-site. They were based in Lower Hutt at the doctor's Silver Stream. So people did have to travel outside their neighbourhood to see a doctor. And so patients were either being seen by them very rarely, or they were doing telehealth. They have a small team basically of doctors that are based around the country who are doing virtual consultations. And we've heard from so many experts that is a good it's a good interim measure, but it's not the best way to be seeing patients. You know, especially kids, you can't sort of cite them and go, what is actually wrong with this crying sick baby? You know, you need to sort of look at the child.
So, and that even seems bizarre to me. So they're enrolled at one clinic. Their doctor is technically at that clinic, but actually not working at that clinic.
Yeah, it's a weird kind of, it's an overlap, I guess, in the different clinics that this overall company, Green Cross Health, owns. So they own the chain of clinics called The Doctors, insert suburb here kind of thing. Okay. And so they bought High Street Health Hub. They also own The Doctors in Silver Stream, and they lost all their management, essentially, in High Street Health. And so they placed their doctor out at Silver Stream to be supported. You know, they're working without a practice manager. They have been for a couple of months. And so it was, I think, an easier way to condense the number of staff that were required to actually keep a doctor's clinic running.
So what is Green Cross telling you about why they've had such a hard time replacing doctors?
Green Cross have basically said, you know, it's so hard to recruit. And that is true. You know, this is not just a problem that is faced by Green Cross or by even just Lower Hutt. You know, this is a nationwide problem where we know there are not enough staff and people are really struggling to get appointments or even just enrol in a doctor all over New Zealand. So I think to some extent that is valid. But it does also clash somewhat with what we're hearing about the way that the practice was run. You know, people are telling us, people who should know, people that worked there, and people that have been speaking to their doctors about what's going on, why can I never see you? And they're saying it's being run it's being run like a business instead of like a doctor's clinic.
What are you hearing from former staff about the culture there?
Yeah, so I've got a couple of emails. One person wrote in, Green Cross is one of the worst organisations I have ever worked for. The focus is absolutely on the bottom line. And then they go on to discuss just the amount of pressure that they put on all the clinical staff to work overtime, unpaid. There's the added complexity of Lower Hutt being really fully booked up, essentially, in terms of GP allocations. So people can't even move clinics. You know, they don't even have the choice of taking their business elsewhere, I guess you could say. But yeah, so mostly just a lot of frustrated people. So many emails since then, you know, people giving their, even past staff, you know, have been getting in touch and saying this was honestly such an awful situation to be working in.
The patients have had some pretty strong words too. Here are some of the reviews left about the clinic.
This person's talked about cancelled appointments. This has been kind of a recurring trend as well. You know, they cancelled an appointment on me with 1 hour and 50 minutes notice. The appointment was for a recurring medication that they had. And then they rescheduled it and that was bumped out again. There's been talk of, you know, doctors or nurses calling back and reminding about appointments or changing appointments even, and saying, you should check, you know, make sure you check that this is going ahead, because the unreliability of it is a real theme too. People are saying that their appointments are cancelled, or that they call to double check and they say, yep, all good, and then an hour beforehand it's cancelled for, you know, with no replacement offered for another month.
Wow.
So, yeah, real anxiety about being able to get repeat prescriptions, any of that kind of stuff, especially if you've got a chronic illness, especially for kids with, you know, with higher needs that need medication. People that get recurring things, even as basic as B12 injections, you know. That's, it's a real anxiety for people is what we're hearing.
What kind of stories are you getting from the patients who aren't getting seen at this clinic?
Yeah, so a lot of people have been saying just the struggle, firstly, with getting someone on the phone. And I think we can all sort of attest how annoying that is. You know, you sit on hold for, hours, they're saying. There was one woman who said that she sat on hold for a couple of hours, and then she was meant to talk to a nurse for a prescription, and then the nurse answered, and she was so flustered that someone had finally answered that she hung up the call, and then she had to wait another month. And it's funny, but you can just picture it, eh?
Yeah.
It's just, imagine the frustration. And yeah, so people with such long wait times, one woman was talking about her partner needing a medical certificate. It's simple as a medical certificate, and she couldn't get an appointment. It was going to be 3 weeks. She was like, well, he's going to be back at work by then, doesn't matter. So we ended up going through telehealth with a doctor who didn't have his records, wasn't aware of, underlying conditions, and just sort of ticks and boxes. Another patient got in touch and said they just described really the feeling of being unsupported and not being able to talk to a doctor that knows you. And I think that is a privilege for sure. I mean, as a kid, I went to the same doctor, and it was like, we know our doctor. And now that's just not a thing, because doctors are so scarce that the patients are shared around, and you don't have that relationship. And I think that's especially hard when you've got kids. More people are talking about kids missing immunisations. That's a real concern, because if you can't get an appointment, those have to be quite well timed, and that's just not an option here. So, yeah, those are some of the things. A lot of people have talked about the frustration of having to pay for things like prescriptions or appointments at times that don't suit them, or when they haven't been fulfilled, or when they feel like they've been given the runaround. And I think, generally patience is running thin among patients.
There's also a knock-on effect, right? If you can't get in to see your GP and something is wrong and it's building up, and then eventually you end up in ED, don't you? Or you
Absolutely.
end up in...
And that, ironically, I mean, you sort of asked before, but that costs us more money as a country. When people put off seeing a doctor, either because they find it really difficult to make that appointment, to get through, to see someone, to go and do it, or whether it's that they literally can't get in to see their doctor at all, and they end up in after hours, and that costs a lot more. That's not accessible for a lot of people. And so you're right, when people start delaying things, health conditions get worse, something that might have been really easily fixable with some antibiotics. It can really snowball, and people end up really sick, and then they are in hospital, occupying hospital beds, and that's worse for everyone, because obviously those are scarce too.
Meanwhile, even if Green Cross is losing the PR battle, it's doing well financially. After all, it's still getting government funding for 9,000 enrolled patients.
So across Green Cross's clinics across New Zealand, their enrolled patients went up 9% in a year. We're losing doctors, but we're gaining patients. And a lot of patients are saying, when they've talked to their doctors, or the doctors that have got in touch with us even, were saying, we grew really fast. And of course that's great if you're a business. I mean, according to the Green Cross 2024 annual report, their medical revenue was up 5% to more than 140 million. Their operating profit fell slightly to 15 million, apparently as a result of COVID and those labour cost pressures. You need to pay your doctors more to retain them, essentially. But they're still making a profit here. And so the idea that it's being run as a business is sort of that main maybe red flag, we'll call it.
My understanding is that funding is based on how many patients are enrolled, like you were saying. So it follows if you've got 9,000 patients enrolled and 1 or now 2 doctors, that's more profitable than if you have 9,000 patients enrolled and 10 doctors, right?
Of course, yeah.
You don't have the outgoings.
And you can minimise the way that it's being done right now. You can minimise the expenditure on admin staff, on, not in this case, but maybe a building. If you're doing telehealth, that's sustainably cheaper. So that I'd say that's accurate.
Let's go back to the funding model. As Brian was explaining earlier, clinics get funding from the government for patients who are enrolled with them.
The funding system we run in New Zealand is a mixed model. It's a capitation funding system where a fee is given per patient that signs up to a practice, and then patients, sort of subsidise that with what's called a co-pay. The government's offer of 4% on capitation and overall 5.58%, which is part of the co-pay increase, was not enough. We presently estimate there's an underlying funding deficit of about 14% that's built up over the last 10 years. So, there is real concerns over the offer that was made. It was rejected by the sector. There's real concerns over the potential sustainability of a number of general practices around the country which are working on very thin margins, or in many cases actually operating at a loss. And over time there is a funding deficit that's built up that hasn't been addressed. So these concerns are very, very real. They're now very apparent, and certainly we are talking to the government that this funding model urgently needs to be overhauled to address the issues we're seeing in the sector.
So the 4% offer is to increase baseline funding, but the government's also relaxed restraints on the size of increases on patient co-payments. Good news for clinics' bottom lines, bad news, again, for patients.
Patient co-payments, that is what the patient pays to see the doctor, we will allow to go up by about 7.78%, so the patient pays more. That's one of the bigger increases we've seen in the last few years, and that burden, I suppose, has been placed more on the patient in this particular funding round, but the overall offer is not adequate.
So even with that increase in copay, which is going to be huge for a lot of patients, it's still leaving GP clinics with that leaving them short.
So that overall increase in copay plus capitation leads to a 5.58% increase in overall funding for general practice. We estimate over the last year the increase in costs has been about 10%. So again, there's a deficit there. And in the background, there's this 14% underfunding that's developed over the last 10 years. So this is really getting quite critical in terms of what's happening.
It feels like at some point a doctor's office would be disincentivized from seeing a patient regularly.
Look, there have been some concerns over that, and that is a very fair comment. Because what we do know about the way the system is structured, patients with more complex medical need who visit more often, the clinic, essentially, if you want to be blunt about it, won't make money at some point because of the way the system is structured. So that is problematic, and it does need to be fixed. But just to demonstrate the point, at my practice in East Pororoa, we have a very high needs practice with Māori, Pacific and refugee, about 90% high needs. We did a University of Otago study last year where we selected 10 patients at random with diabetes and complex need. Over a 12-month period, they contacted on average the practice through various means 24 times. So that was the amount of demand or work that was required by the practice. Yet the government's capitation fee is based on 3 interactions a year. So we can see the problem that's emerging here, that the copay and the capitation itself does not compensate for the amount of effort that's required to properly service patients with high complex need.
That's it for today. The Detail is a newsroom production supported by RNZ and NZ On Air. Today's episode was engineered by Steve Burridge. Gwen McClure did all the real work on it, but she got sick and she's not even trying to get to a doctor. I'm Alexia Russell. Stay well.